All right, here's your cardiovascular NCLEX review or your review for your HESI. Uh, let's start off with the risk factors for cardiovascular disease. So when we talk about the heart, right, when we talk about the heart, we're gonna note down everything that increases the workload of the heart. Now, we gotta focus on two different non-modifiable versus modifiable risk factors. Non-modifiable risk factors, we can't change anything about them, but NCLEX likes to ask you about modifiable risk factors. Now, your big three, I always call this the big three: smoking, high cholesterol, smoking, hypertension, and diabetes. Those are your big three for almost all your diseases. Cardiac, no difference. Smoking, hypertension, diabetes. One biggest three risk factors for your cardiac disease. So those are things we can change. A lot of those questions will be kind of geared towards more educational type questions for you. Okay? Now, what are the effects of aging on all these structures? The walls get thinner, they get less flexible, your valves gets a lot weaker, and all those arteries and veins, they get a little more stiff. Right? They get a little more stiff. If we talk about the cardiac cycle, you got to note down the electrical pathway of that. Now, this is discussed in my video on interpreting EKG rhythm, so I'm not going to fully focus on this too much. So I'm going to skip over two sections right here that covers dysrhythmias. All right, let's talk about one big thing about cardiac: angina pectoralis or angina pectoris. Nice little term for chest pain. We're going to talk about the different types of chest pain. You have to sectionalize your two types of chest pain as stable versus unstable. All right, stable versus unstable. So stable versus unstable chest pain. Your stable is your type of chest pain that does go away, right? It goes away with rest, goes away with nitroglycerin, right? Or there's a specific cause such as exercise and it goes away with rest. Unstable chest pain, on the other hand, doesn't go away with rest, doesn't go away with nitroglycerin, and may be a precursor to what we call a myocardial infarction. So your myocardial infarction, an MI, basically a heart attack, right? There's a clot heading into one of the main coronary arteries, causing that damage, that ischemia or that necrosis in those areas. Now, those diabetics have a higher risk of this because of that neuropathy. Plus, leading number one for MI as well is your high cholesterol, because those fat and cholesterol plaques tend to build up in those areas. Now, big thing to note down: pain is not relieved by rest. Okay? Now, what can happen with an MI? Big thing that can happen is you can have an arrhythmia. Depending on where that damage is, it could damage that electrical conduction in that area, causing that arrhythmia. That is the number one thing that people that get an MI, that's the number one thing that they die from, is a cardiac arrest because of an arrhythmia or dysrhythmia. Now, what do we do? How do we treat this? MONA is our go-to. In expanded terms, MONA TAS, but let's review MONA. Morphine, oxygen, nitroglycerin, aspirin. Morphine, it lowers the pain sensations, right? Lowers pain, lowers respiratory rate. The oxygen, if oxygenation to the area is the problem, we increase oxygenation and hopefully we can alleviate some of those oxygenation needs for the body. Nitroglycerin, note your nitroglycerin as being given 3 times every 5 minutes and checking that blood pressure before you give it every 5 minutes. Now, after you check blood pressure, you will be holding that nitroglycerin. Per your NCLEX, it could be a range of 90 to 100 on systolic. Anything lower than that, you'll be holding your aspirin. We'll be giving some beta blockers, right? We could be giving some beta blockers because beta blockers have shown that decreased workload of the heart by lowering that blood pressure and lowering that heart rate. Cholesterol medications, of course, if it's caused by a fat plaque, we don't want to increase that fat deposit in that area. Of course, we got to talk about, again, the modifiable risk factors. Now, if you get consecutive MIs, you get multiple MIs, it can lead to what we call a heart failure. Very easy to note: right-sided heart failure versus left-sided heart failure. If you remember anatomy, right, the heart is a nice little freeway, and if you cause a traffic jam in one of the areas, fluid tends to back up. That's it. If you remember that pathway, you should be good. Now, the blood from the body returns to where? The right side of the heart. So meaning, if there's right side heart failure, the fluid backs up into the body, right? Again, if fluid goes into the right side of the heart, if there's right side heart failure, meaning the pump's dead, fluid backs up into the body. Now, on the left side of the heart, fluid comes from the lungs and heads to the left side of the heart. So if there's problems with the left side of the heart, fluid backs up again into the lungs. So symptoms are going to be more on the lungs. So on the right side of heart failure, any symptom that they note down that doesn't have to do with the lungs, meaning fatigue, right? Fatigue, liver issues, spleen issues, ascites, meaning that fluid buildup in the stomach, distended JVDs, right? Jugular vein distension, weight gain, edema, anything that has to do with the body, you're going to note that down as right side heart failure. On the left side, on the other hand, number one, if it ends with a apnea, dyspnea, tachypnea, bradypnea, you're going to be choosing left side heart failure. All your lung sounds, crackles, wheeze, rhonchi, right? Those are going to be all, again, left-sided. All the apneas, again, those are the main things. Restlessness and confusion are a sign of hypoxia, so note down that could also be a sign of left side heart failure. Now, what do we do for heart failure? Heart failure is a problem with the pump, meaning there's too much fluid in the body because the fluid's not moving and not being sent into the kidneys to be excreted. That's it. So what do? Get rid of that fluid. We got two things to do. We can get rid of that fluid and we can also improve the contractility of the heart. Diuretics is our key. We got to get rid of that fluid, but we can't just get rid of that fluid without improving the heart. The big thing we got to do is give something to help that heart beat a little better. And that's going to be your digitalis, or what you know as digoxin. Very important thing to note down about digoxin, check the apical pulse. When are we holding it? Apical pulse less than 60. If you don't know your apical pulse location yet, very important for you to kind of note that, just because NCLEX can give you a nice little picture there and have you point that out, all right? So, 4th, 5th intercostal, mid-clavicular line, middle of the clavicle, right? 4th and 5th intercostal. Big thing to check is digoxin toxicity. So note down your digoxin toxicity. Big changes is the vision, your halo ring vision. But any vision that they give you, double vision, photosensitivity, you might want to pick that as an answer for your digoxin toxicity. Okay. Lab values to check. We want to check kidneys. Hypokalemia can cause an increase in digoxin toxicity as well. BNP is your peptide that's an indicator of heart failure. It's a ventricle. It's one of the things that the ventricle releases when there's a little bit of damage there. So we gotta note down as an increase in BNP may be a sign of heart failure. All right, valvular heart disease. Those valves that we talk about, right? Those aortic, pulmonic, tri versus bi valves. Anytime there's insufficiency or regurgitation, anytime there's stenosis, those are what we call valve disease. Now, what do we do about them? Usually, we treat them symptomatically, but unless there's severe symptoms, then we can go for the surgical intervention, which is a valve replacement. Okay. All right, rheumatic heart disease. One big keyword you got to remember: strep, and where the strep stem from. All right, strep throat. I want you to remember strep throat. So it's in your mouth. So big thing there is anyone that has had open heart surgery or any type of cardiac surgery, they do have to note this down whenever they have to let their dentist, orthodontist know whenever they're getting any dental work done. Because one thing is that strep can travel down to those valves and cause that valvular disease, or rheumatic heart disease is what it can stem from. So very important for you to note that.